So good evening, ladies and gentlemen. Welcome to the main arena here at PCR London Valve 2019. It's a great pleasure for me to co-chair this session with Thomas Modine from Lille, France, and I'm Bernard Prendergast from London in the UK. We have a panel who are going to join us, some of whom are going to be providing presentations as well this evening. So I'd be very grateful if Jörg Hausleiter, Philippe Lurs, Giuseppe Tarantini, John Webb and Stefan Windecker would come and join us here on the main arena stage, and that can be your launch pad for your presentations at the relevant moment. So as you all know, we've come a long way in a short space of time, and there's a lot to discuss in this sort of opening plenary session regarding the scope and the scale of transcatheter heart valve intervention in 2019. And Thomas, if I could ask you just to walk the main arena audience through our agenda this evening.
Thank you, Bernard. So, good afternoon, everybody. It's working. Okay, so it's my task to introduce the session and the objectives of the session. So thank you, everybody, for being here with us. So the speakers will cover different topics, which aim is the following. First, to learn about the implications of valve design, why such design is favorable for the anatomy, but also that translates into the beautiful results we know in the reports and the literature, to understand current and future patient transcatheter treatment options. It's evolving over time, and it's nice to discuss that again, to anticipate the future challenges of the heart team. The heart team place is very important to debate. So the panelists will be covering all the aspects of these questions that we are questioning here today. Professor Windecker, Professor Tarantini, Professor Webb, Professor Lurs, Hausleiter, and finally, Mr. Prendergast. So the first speaker I'm going to call is Stefan Windecker. He will open the ceremony. And it's my honor to open your presentation.
Thank you, Bernard. Thank you, Thomas. Good evening, ladies and gentlemen. The paradigm has changed in aortic valve disease management, and the reason is a foundation of evidence built on several randomized clinical trials that have been first performed in extreme and high-risk patients that have shown that TAVR is either superior to medical treatment or at least comparable to surgical aortic valve replacement. This was subsequently followed by the assessment of patients at intermediate risk, where again TAVI as compared to surgical aortic valve replacement showed similar results, or if performed by the transfemoral route, superior results also in patients with concomitant coronary artery disease. And most recently there has been the advent of trials that compared the two treatment modalities in low-risk patients, again indicating superior or at least a similar outcome comparing TAVI and surgical aortic valve replacement. If we look both at a patient perspective and a healthcare perspective, we have to come to acknowledge that in terms of benefits, improved quality of life, less invasive procedures, and better resource utilization, transcatheter valve implantation is superior to surgery. Similarly, if we look at procedural outcome and intermediate outcome and look at risks, including mortality that is decreased, particularly when we address the transfemoral route, the procedural complications that are reduced, notably renal failure, atrial fibrillation, and bleeding, as well as readmissions, then also from a healthcare perspective, transcatheter aortic valve implantation fares superior to surgical aortic valve replacement. Now, how do we put this in clinical context, and how do we move from here? First of all, the old risk assessment in extreme, high, intermediate, and low risk is no longer necessary. Instead, the favorable outcomes of transcatheter aortic valve implantation are consistent across the entire risk spectrum, suggesting that surgical risk estimation is no longer the basis to guide the choice between TAVI and SAVR. And therefore, the traditional heart team concept, where the default was to consider patients for surgical aortic valve replacement and that not suitable or at increased risk for surgery, will transform into a reverse scheme where per default the assessment will be for transcatheter aortic valve implantation, and only those in whom the procedure cannot be performed safely will be considered for surgical aortic valve replacement. So the heart team will in the future not consider surgical risk, but rather weigh clinical and anatomic characteristics to identify the best treatment option for individual patients with transfemoral TAVI replacing surgical aortic valve replacement as a default therapy. From an historical point of view, several things have changed. On the left side, you see the surgical era. On the right side, the more recent TAVI era. So how to treat? In the past, it was a choice between mechanical prosthesis and tissue valves. Today, it's a choice between interventions. How to choose was determined by age and risk scores. Today, it will be by clinical and anatomical factors. And finally, who makes the choice? Traditionally, this was done by the cardiac surgeon. Today, this is done by the heart team. Now, how do we translate this knowledge into the future? First of all, these are contemporary data assembled by Bernard Jung for the Euro Heart Survey, looking at the prevalence of valve disease, where aortic stenosis is the most common valve disease, but importantly, the implementation of Class 1 indications for performed and scheduled interventions. And also one has to acknowledge that this overall is already an acceptable achievement, that 80% of those who have a Class 1 indication undergo the procedure. Still, there remains room for improvement, with 20% of patients still not considered to undergo a procedure for some reason, although they fulfill a Class 1 indication. And therefore, I'm closing with this slide indicating that although we are privileged to have the technology available across Europe, there's still wide heterogeneity across the various European regions, and that the full adoption of transcatheter aortic valve implantation still will require time and adoption of the full scale of the clinical guidelines, including the newest incorporation of evidence in low-risk patients. Thank you very much for your attention.
So thank you very much, Stefan. I should say that this session is using the React at PCR system via the app, so please do send your questions through to us. Thomas is screening them constantly, and at the moment there are no questions, so please do send those through so that we can engage you in the session. It would be interesting to hear the views of the panel, how these new wisdoms have impacted on practice in the weekly turnover of new referrals, discussions with surgeons, and the conduct of the heart team. Perhaps, John, could we ask you how you've implemented this in your unit in Vancouver?
Well, we're still in a state of evolution in Canada because we don't yet have funding for low-risk patients, but we've been doing low-risk patients, in fact, I think for a long time, in the patients who are elderly or advanced age, often actually at low surgical risk. And I think that really the surgeons in my part of the world have come to an understanding that this is really the way things are going, and it's become very collegial, to be perfectly honest, and not very competitive.
And does the same prevail in Germany and in Italy?
Well, in Germany, at least in some parts of the country, we do have some reimbursement also for low risks. But I think we have also to be careful, despite all enthusiasm, also regarding partner 3, all those younger patients with aortic stenosis were not well represented. So what are we doing really with a 60-year-old with aortic stenosis? How long will these valves last? And what about the pacemaker risk? I think this is still, we have great data, but we have to see really now in those patients who have, especially the younger ones or with the bicuspid aortic stenosis, how are we going to deal with those patients?
Yeah. And these are very important questions for us all, of course. Giuseppe.
Okay, in Italy, the most important thing is not the risk, because in the past years we have already been treating patients at low risk, but the point is that they were 80 years old or older. So the real novelty to face, I think, in our country is to deal with low risk and younger patients. Because based on the two low risk trial, what we have is the average age is 70 years old. And actually, you know, for the moment, the art team doesn't seem so prepared to face this kind of younger patient. So I think in perspective, the most important thing to work as societies is to try to standardize and objectivate the heart team for these younger patients.
And Stefan, can we return to you in Switzerland and maybe within a European Society of Cardiology perspective as well? How is this going to pan out, do you feel?
So currently in Switzerland, there is also a reimbursement scheme which builds on the old concept of risk stratification, and that's what I try to attempt. I think this is not a useful concept because TAVI versus surgery works irrespective of that risk categorization. I think this is the wrong question to ask. The question should be rather, can TAVI performed safely or as safely as surgery, and only if that cannot be performed, then to consider surgery. Of course, this is a great responsibility, and I think this is the change that needs to take place. That is, can I do a procedure without a risk of coronary obstruction? Can I do a procedure where I have less than 1% risk of relevant paravalvular leak? Can I do a procedure where the pacemaker risk is not higher than if I would do a surgical procedure? So I think these are the questions that need to be addressed.
We've got some questions here, Thomas.
From the audience. I want you to answer the first one, please, and then I have a question for you.
Yes, so I think this is a very important question, and it has been already mentioned by the panel that in terms of the evidence, we have evidence in relatively old, low-risk patients. But this is not a fault by the trials, but really the fact of the calculation of the risk scores. The second thing I would pose the question back to you, Thomas, as a surgeon. There are not so many young patients with degenerative aortic valve stenosis. So if we talk at least about tricuspid degenerative aortic stenosis, the mean age is in the range of 75. Younger patients, they may have congenital abnormalities, they may have bicuspid disease, they may have aortic root disease, but that's a completely different patient population. So I would submit to you there are not so many patients that are young, low risk in the age range of 65. Now I think the surgeons usually distinguish when they implant a mechanical prosthesis, and I think very young patients with some kind of conditions where the aortic stenosis may be incurred at a very young age, less than 50, I think that discussion still needs to be entertained. I think in the age range of 50 to 65, it should be an individual decision making between all involved therapeutic disciplines, the patient. But above 65, I think it will be bioprosthesis, and the question will be driven by clinical and anatomic factors, whether it's TAVI or surgery.
This is a good summary of the presentation. I mean, the question is there is a lot of overlapping and interpretation between the risk scores and the age of the patient. And I mean, as a surgeon, surgeons have not been calculating the risk scores for patients who are 65 and below. So why should we do it for TAVI, to be honest? So with this regard, I know there's a lot of surgeons in the room, and I would be happy that you could react directly, not only using the iPad. Face-to-face confrontation is always important. So I want to ask a question. I mean, what's lacking today is the increase the adoption from the surgical side of TAVI, which have been shown to be effective, safe, and durable to some extent. So what is lacking from your point of view to make the surgeons really accept what we have been assessing now in the last 5 or 10 years, from your cardiologist's point of view? Because we are living turbulences in this our team concept.
Yes. No, I think surgeons will have no problem accepting that TAVI will be the default technique for the mainstream, simple, isolated aortic stenosis. I rather think they will focus on what is surgical disease, that is patients with severe aortic stenosis and severe coronary artery disease. That is a patient who has multi-valve lesions, primary MR and aortic stenosis that requires some surgical interaction. These are patients that have repair of the aortic, need repair of the ascending aorta. So I think for the surgeons, it will be, the appetite will increase with the more complex diseases that are not amenable to minimally invasive techniques.
And finally, we had an observation from the audience about the way the paradigm may be different in more advantaged countries compared with those who are more economically disadvantaged.
Yes, but I think, you know, at least I'm coming from a DRG environment, and the DRG for transcatheter aortic valve implantation is no higher than that for surgical aortic valve replacement. So the societal cost is already no different. And as everything, cost is a moving target. That is, with more efficiency, with more competition, the cost will be subject to change, and it will go in a direction that is favorable for TAVI.
And also the way we organize our cath labs and surgical rooms, the number of people present, the length of stay in the hospital. I think this is a global package that we should integrate once for good and calculate the cost effectiveness.
Indeed. So we should move on now. So thank you very much, Stefan, for that stimulating introduction. We're now going to take two presentations back to back. The first from Giuseppe Tarantini regarding the issues of valve design and the way it may impact on the future of the patient. And that will be followed by John Webb talking about the concepts of redo transcatheter heart valve procedures and some of his experiences in recent cases.
Thank you, Bernard. So as you can see by the title, I have two focuses to share with you on the valve design and the patient future. Let's start from the first point. I prefer to use the word valve system rather than design because actually we have to admit that we have different flowers and different stems across the different technology that we have so far. We have balloon expandable, mechanical expansion, we have self-expandable valve. If we add this consideration to the different iteration of the same valve that we have, for instance, XT, S3, Sapien Ultra, there are so many combinations together with the different stems generation that it takes half an hour to discuss all of these things. So I've decided to look the things the way around, and I've decided to start with the patient future, and this is going to be also my storyboard. Actually moving from the cath lab to the long-term follow-up of this patient, I would like to share with you these outcomes and this future direction to find out in some way, you know, the technological correlates that may matter in terms of best performance for each of these outcomes. So let's start with the vascular complication. This is the frame, the format that I'm going to use also for the next slides. The slide is too busy, but here you can see on the left the different trial, different risk profile of the patient, high, extreme, intermediate, low risk, and the different series of prostheses that have been used so far. Just to simplify these slides, I just want to report the best performance reported so far is not, actually we're not supposed to make a comparison between valves because we don't have so much randomized trial with this regard, but what we can say is that the lowest rate of vascular complication has been reported for the Evolute low risk and partner 3 trial that include low-risk patients. What might be the technicality that stay on background of this result? For sure, this might be, you know, one reason, that is the THV delivery cath that is compatible with a minimal vessel size of at least 5 millimeters up to 5.5. Moving to the PVL, that is, you know, something that is of utmost importance after TAVI. Again, the same format, same risk profile, different prosthesis. And again, what may be, you know, the technology background to get this result? As you can see, the best performance seems to belongs to these two valves that are the Lotus valve and the Sapien 3 valve. Whatever is the risk profile, because in this case with the partner 2 S3, we are in the intermediate cohort, partner 3 is low risk. What might be the rationale, the engineeristic rationale for that? The intraannular design, the outer skirt, and the high radial strength. Strictly correlated to the same logic are the fact that with these two valves, you have a little higher gradient compared to all the other prostheses. This difference is 12 against about 8. Now we have a recent randomized trial, it is the SCOPE 1, where the difference between the supraannular accurate versus Sapien 3 is 7 against 11. No one knows at long-term follow-up if this 3 or 4 millimeter of mercury of difference matter in terms on clinical ground. Moving fast forward to the stroke rate, these are the list, the different frequencies of all stroke rate reported at 1 year. What are the best performance across trial? Again, what we have is that in the partner 2S3 and the partner 3, respectively for intermediate and low risk, what we can see is that the Sapien valve is equal or superior to the other best performing valve with this regard, that is the core valve. What might be the rationale for that? The steering flex catheter, probably. The less need for pre or post dilatation, the predictability of implantation. Pacemaker rate. Everybody knows that at long-term follow-up, the implantation of pacemaker matter a lot in terms of outcome because it correlates with all-cause mortality. And again, looking at the trials, with a partner inoperable, high risk, or partner 3 that is low risk, and in the SCOPE 1, the accurate, seems to perform quite better compared to the other reported rates for the other valve and the other trials, and the rationale for that, again, might be the predictability, the footprint. This is very important because in the distal part of this valve, we have an open cell design that matters to skip the east bundle of the conduction, to avoid conduction disturbances. And finally, we don't need actually to make a huge oversizing with this valve. Moving to something that for me is even more important, especially considering the lower risk patient and mostly the younger patient. So the one is the durability. We are starting to see this paper, just case reports, about 10 years of follow-up. This has been reported from the John Webb group on New England. But the real question is, should we expect long-term durability differences among prostheses? Actually, we may argue, that's probably the risk, but we don't have compelling evidence on that because we have intraannular versus supraannular valve. We have different leaflet characteristics and thickness. We have totally different anti-calcification process. The first generation didn't have any anti-calcification process. Different stent, frame deployment, oversizing, and circularity. Just to sum up, what I can say is that we have to wait the next 5 years to have at least, some robust data about the durability of at least 10 years of follow-up. These 2 points are, for me, the most important things. The one is the coronary access, and the other one is the redo TAVI, that in the next 5 years we will see more and more. The first point is that the valves are completely different related to the frame. We have intraannular, supraannular. At the same time, we have closed cell design, more closed cell design like the core valve, and we have open cell design. This might make the difference. I cannot discuss about all the valves. Just this is a comparison between the 2 global leaders, just to discuss some challenges in coronary access. First of all, with the core valve, we are supraannular, supracoronary, not subcoronary. The skirt is asymmetrical in the core valve. At the level of the commissure is 26. On the contrary, with a short valve, we have an even distribution and circularity of the skirt. The other point is the more closed cell of some self-expandable valve. And finally, there is the issue of redo TAVR. That might be an issue, and I'll show you in the next few slides. What we have to consider is 2 things, 2 very simple things. The first one is the risk plane. What is the risk plane? The risk plane is the level under which a catheter, a coronary catheter, will not be able to cross the valve frame once the leaflets are tilted up. Here you can see in this cartoon that this frame, the wrist plane is up to 22 millimeter for the Sapien, 26 for the core valve, and up to 31 for the Accurate. For the Portico is about 29. So you have to imagine when you tilt up these leaflets going into with another TAVI that you create a kind of covered stent, and the height is from 22 to 31. The second point is the VTA. The VTA, you know very well this concept when you go with the TAV in valve when the valve is a sutureless valve. So, pardon me, is a stentless valve. So you have to measure this distance to be sure that you cannot create any problem with the coronary. So let's try to simplify in real clinical practice. We might have three situations. The first one is that the wrist plane stays below the coronary artery. In this case, you won't have any problem, even with the valve in valve, to create any problem at the level of the coronaries. The opposite is when the wrist plane stays above the coronary artery and you have a very narrow sinotubular junction. At this level, it's impossible to incannulate the coronary from above, top down, so the only way is to go through the struts, but when you have the leaflets tilt up, you will have the same problem that you have with the sutureless valve, so it is unfeasible. And finally, we have something that stays in between, that is a gray zone, when you stay with the wrist plane above the coronaries, but you have a lot of room to go aside with the catheter and to cannulate from above the coronary artery. So based on this assumption, the three simple assumptions, we analyze some cases and we submitted the paper just to highlight this last slide with all of you. So the feasibility based on these three different scenarios, the feasibility to incannulate with the Sapien 3 is 68% compared to less than 20% with the other two valves. The unfeasibility is 23% with the Sapien compared to about 40% with the other supraannular valve. And then we have the gray zone it's difficult to sort out unless you try to go with a catheter in a concrete manner after the TAV implantation to understand if it is possible to cannulate these arteries. So my last slide is, to conclude, related to why valve design matters. I have to make two citations. One, I'm a little bit biased because he's one of the brightest scientists that we have. So, of all time, that is an Italian guy, is Leonardo da Vinci, that said, the structure is always the mirror of function. So structure matters a lot. And moving to the current time, this is the citation of, Jeffrey Zedman. He's a very famous designer that said that when the content has always to precede designs, when design has not any content, it's just decoration. Thank you for your attention.
So Giuseppe, thank you very much indeed. You've raised all the relevant issues which are important for clinicians now and in the future. And we're now going to ask John Webb to join us to show us some cases relating to the challenges and the practicalities associated with redo TAVI intervention. There's a lot of people standing at the back and there are lots of seats on the side aisles here. So please do feel to come round and fill the seats. Don't stand up for the next hour. You'll get very tired. John.
Well, thank you very much. So I'm going to talk a little bit about redo TAVR and redo surgery and valve and valve. And I think this is all intertwined. It'll be very complicated in the future to decide what's best for individual patients. We have pretty good anticipated durability from in vitro studies of transcatheter valves as compared to surgical valves. This is a simulation out to 1 billion cycles, equivalent to 25 years. But we know this isn't going to happen in real life. We have pretty good durability demonstrated out to 5 years with several different valves now. And in surgery, we have very good durability data out to a long period of time, and we often talk about it to 15 years. But if you look there in the red box, you can see that there's actually very few numbers of patients that have had durability demonstrated in surgical valves. We're only around 150 out to that long. In fact, we have somewhat similar data from multiple transcatheter valve study showing late durability, which is equivalent, I think, to surgery. And now we have 10-year survivors that are demonstrating that, in fact, the valves can sometimes last this long. Here's one of ours, our very first one some years ago, and there's a mean gradient of 11 with just mild insufficiency, with actually an equine pericardial non-anticalcification treatment of the valve. But all of these valves are going to fail, both surgical and transcatheter valves. There's a surgical on the left, transcatheter on the right, again, one of our early Cribbie-Edwards valves. And we have a lot of data which has demonstrated that we have pretty good results with valve for failed surgical valves, perhaps better than redo surgery. This is a meta-analysis of 6 studies comparing valve versus redo surgery, and this demonstrated that despite higher predicted surgical risk in the valve patients, there was no difference in mortality and less of other sorts of complications. We have our own data from the partner trial showing good 3-year durability, but I think we can anticipate that valve implants may not be as durable as just repeat surgery should you survive the procedure, because valve implants are never properly expanded, and that is going to affect durability. We've learned how to do valve implants better. We now implant very much higher with the intra-annular valve, such that they're not necessarily even truly intra-annular anymore. Here's a very small MitraFlow 21 with a mean gradient of 13 with this very high implant. And we have new data just demonstrating the SAPIEN 3 valve, for instance, and other valves, the evolutor, doing much better than the early valves did in the early studies. Very good outcomes and compared to what you would expect with repeat surgery. And here's a comparison of a meta-analysis of repeat surgical outcomes, 166 patients, versus the VIVID SAPIEN 3 registry, about the same number of patients, just much fewer complications. I think durability may not be quite the same, though. But in terms of valve and surgical valves, this is from Danny DeVere, just showing that most of these patients are coming to a redo procedure somewhere around 8 or 9 years, and I think it's reasonable to anticipate that as we move into younger patients, it's going to be earlier because the valves are not going to be that durable, and that's an issue. So what will happen when transcatheter valves fail? It's going to be a big issue. Now, you can take them out, just like you can do redo surgery. There's a SAPIEN, and some of these valves may be incorporated more into the ascending aorta. It may be somewhat more difficult or require more extensive surgery, but certainly TAVR in TAVR or TAVI in TAVI is possible. Here's a patient that had a porcelain aorta and a SAPIEN valve implanted transapical with a mean gradient of 14. 10 years later, the procedure repeated with a SAPIEN 3, both underexpanded because of the severely dilated aorta. And still, you can see the coronaries above this valve. This can actually be done again. And at age 78, it may well need to be done again. We now have data from the redo TAVR registry, which was presented by one of our fellows at TCT just very recently, 34 centers to date in this. And of this, if we go down here, we can see we have 211 patients that had repeat TAVR for failed transcatheter valve implant, structural failure. And in fact, the reduction in gradients is quite dramatic. It's even more so in stenotic than regurgitant valves, and more so in small versus large valves. And then here's the mean gradients compared to a number of valve registries with redo TAVR lower, obviously not directly comparable, but we're doing pretty well, I think, with this. No regurgitation, as you would expect, because the sealing is very good inside transcatheter valves. Functional class improves dramatically after redo TAVR. And in fact, the early mortality and the 1-year mortality is, I think, really pretty respectable compared to any other series. Now, one of the problems with redo TAVR is issues around access to the coronaries. And access to the coronaries after TAVR is one thing, but access when you put a transcatheter valve inside another one is another one. Now, if you do an intra-annular valve below the coronaries, then it's not a problem. As you know, though, we often implant SAPIEN XTs higher, or SAPIEN 3s higher, and they may in fact overlap the coronaries. It may not be a problem initially, but redo TAVR can be a problem if the valve is high and you tack up the leaflets. Similarly with the supraannular valve, it's going to be much more of a problem, not just access, but the potential for actual coronary occlusion because of sealing off the sinus. Here's an example of a accurate valve that's clearly been implanted a little too high, although this patient actually did quite well with that until they came back a year later with an acute myocardial infarction, and the cardiologist involved could not cannulate the coronary arteries. As you remember, the attachments of these leaflets go right up to the top of these struts, way above the coronaries. So you really have to go around them. And you can see on a non-selective aortic root angiogram, there's a new critical tight LAD that they just could not get to. So that's a problem. Now you have a porcelain aorta and the patient needs bypass surgery. 1 year after TAVI. Here's a single core valve where you can see the leaflets just rising up here when you do the injection. They're above the coronaries, very difficult to get down. And here's a patient that I found myself doing a STEMI MI on one night, and I step on the floor and find there's a core valve and another one here, and really no access to the coronaries. It'll be a bigger and bigger problem with redo. Here's an example. You'll be running into the commissures and running into the leaflets of the first valve, and access may often be a problem. Here's an example of a core valve, repeated, the first one, and then the second one 6 millimeters higher, and shortly afterwards occlusion of the coronaries. Now, people say, well, maybe we'll do a basilica, and here's an example of an accurate valve with a basilica procedure being done, and then a sapien valve with reasonable access to the coronaries. But I'd remind you that these valves are not anatomically implanted. There's a patient with the commissures before implantation and then afterwards, so you can't count on the fact that the leaflet will be right in front of the coronary and basilica will be possible. It probably will generally not. So a lot of factors will determine whether TAVR is redoable, including the sinotubular junction dimensions, the length of the surgical leaflets and the coronary height, but also the type of valve and where the commissure attachments are. So there are a number of factors that will determine whether, in fact, TAVR will be repeatable. Now, one thing we may want to do when we implant these valves is just remember that we often crack surgical valves. These videos aren't playing, but there you can see here's a mitral flow before and after cracking, and gradients fallen dramatically with much better opening of the orifice. And you would think also much better durability of the transcatheter valve implant and reduced risk of infarction. Now, we sometimes talk about the Russian doll model. I thought this was kind of interesting. I just saw this last week in a restaurant, so I took the picture. But the question is, how many times are you going to be able to repeat TAVI? Are you going to run out of space after the first repeat procedure or the second one, even if you avoid coronary trapping? Well, I just point out that you can actually expand just as you can crack surgical valves. You don't crack a transcatheter valve, but you can expand them. This, for instance, is a 23 millimeter Sapien XT. So is this. This is a 23 millimeter Sapien XT expanded to 26 with a high pressure balloon, and then a 26 millimeter valve.
Okay, ready at the pacer?
Don't go up till so here's a 10-year patient with a failed Sapien XT, Sapien valve, I guess, Sapien 3 implanted inside.
Slowly.
And first one was grossly underexpanded because of the porcelain aorta, and there you can see maybe we should have taken a 20 millimeter Sapien 3 the second time, because you're not going to be able to over-dilate this very calcified annulus. But in future, I think it'll be very important for us to plan on whether and examine whether this procedure really will be repeatable, because it may not be if the valve is going to obstruct the coronaries. Thank you very much.
So thank you very much, John. As ever, it was a tour de force presentation with some amazing cases that you've been exposed to. The first question from me is, where do you think we're going to get the durability data from? There's your own series, there's international registries, and there is some randomized trials. But will we get the strength and the magnitude of the data to really know we're there?
Our registry has a larger number of patients, but it's not going to get us very good durability data. It's self-reported. And so it is what it is. We have 1 year data, and it's hypothesis forming. But I think, you know, we have a few valve-in-valve trials from industry, but again, they're fairly small, but there will be long-term follow-up. You know, that the issue is that the partner valve-in-valve registry, partner 2, that's a Sapien XT trial. These are all under-expanded, and we know how important that is now. I think we need to think about our sizing inside surgical valves more than we have, and also maybe enlarging the surgical valve if we really want these valves to be durable.
I think it's important to know that we are trying to base our interpretation today on our initial studies, I would say. So we have new valves, new iterations, and this will have definitely a positive or favorable impact of what you're doing. So we have to wait and see. John, I have a beautiful question for you, coming from a surgeon, I guess, in the room. And you, as a cardiologist, I would like you to answer this, please.
How will we train and maintain competency for surgeons who manage patients that I guess can't have TAVR is the point? So how will we train surgeons to do these difficult cases? That's a big problem. And I think one obvious answer is to do this, we probably have to have fewer surgeons to maintain reasonable volume. And I guess that's an issue, isn't it? is fewer numbers of surgeons doing that kind of surgery, but still maintaining volume. So along with this, it may mean fewer sites. It may be that you have to refer your patient to remove the 2 TAVI valves that are already in and adherent to the aorta. So fortunately,
we need better surgeons and better paid surgeons also. I totally agree with you. That's important.
So I think in the interest of time, John, thank you very much for your presentation. Also, Giuseppe, thank you very much indeed. And we're going to...
So the next speaker is my chairman, Mr. Prendergast, who is going to address the Heart Team 2.0 after Stefan.
So thank you very much, Thomas. As some of you may have gathered, one of the central themes of this year's meeting at PCR London Valve is a re-energization of the concept of heart team working. And that's one reason why we've opened our arms very widely to the surgical and imaging community to embrace the heart team concept as we try and move the needle in the management of heart valve disease in the 21st century. So in fact, there is nothing new about the concept of heart team working. And way back in the 1950s, in an era before evidence was required, and an era when common sense prevailed, it was felt to be intuitively obvious that working together as cardiologists and cardiac surgeons was the right way to make progress in the field. Now, I'm not entirely sure that this is what people had in mind when they were making these recommendations, and I'm certain that the infection control officers at my hospital would not be happy with this scenario. But we have in more recent years begun to provide documentation and guidelines in relation to the need for heart team working as the field merges and as the field moves very rapidly. Recognizing that transcatheter valve treatments require a new set of skills and disciplines, and that there is a need to regulate the expansion of these new techniques as the evidence emerges and the durability of the new devices becomes clear. And initially, this was a desirable concept provoked by European position statements, followed by similar transatlantic statements from the ACC-AHA suggesting that it is indeed important. And then for the first time in 2012, the recommendation at a very firm level of guideline statement that heart team working in the field of transcatheter valve interventions was very, very strongly recommended. I think mandatory is a strong word, but certainly very strongly recommended. Now, in the time since 2005, of course, we've moved a very long distance in a very short space of time. And that relates to advances in the devices and the engineering developments that have come in a very short time period. I'm grateful to Giuseppe for this slide. And also a very rapid uptake of activity in most developed countries across the world, with rapid growth of transcatheter aortic valve implantation illustrated on this slide here in blue from the UK data. But I choose this slide because I want to demonstrate that over the decade following 2007, with the commercial release of transcatheter heart valves in the UK, that the volume of surgical activity indicated in red remains stable. In other words, indicating that interventional cardiologists were essentially treating the unmet need of patients who were not being offered surgical aortic valve replacement by the surgical community on account of their age, their comorbidity, and their frailty. So over the years, the heart team concept has evolved year on year effectively in my own practice, and I'm sure in the areas of practice in all of your hospitals here in the main arena. Initially, in the early years, selecting TAVI from an anatomical perspective and a clinical perspective, and offering this new intervention in very high-risk patients, where surgery was off the table. Then refining the technique in the last 6 or 7 years and offering it to older patients with comorbidities based upon evaluation of their risk scores. And then perhaps in the last 2 to 3 years, the realization based upon strong evidence that intermediate risk patients as well benefit from a less invasive transcatheter mediated approach. But this year, of course, is a disruptive year because we have randomized control trial evidence now, as Stefan has told us, across the spectrum of risk, suggesting that TAVI is at least as good as surgery in the majority of patients with aortic stenosis, thereby bringing round the full circle projected by Francesco Mazzano in a series of talks over many years, suggesting that the evolution of intervention for cardiac disease moves from surgery being the only treatment to surgery becoming the gold standard and then the preferred treatment initially for low and intermediate risk patients, followed by the emergence of evidence, the application of newer technologies in lower and lower risk patients, and ultimately Stefan's paradigm shift too, that surgery actually becomes the preferred alternative only in those patients in whom a transcatheter valve approach is inapplicable. And that here indeed is Stefan's slide summarizing this paradigm shift, whereby the heart team will be asked to consider patients with aortic stenosis, and rather than choosing the select few for TAVI, in fact switching the paradigm and selecting the majority for TAVI, and only those who are anatomically unsuitable for the procedure, thereby proceeding towards surgery. And this, of course, is going to be a very important role for the heart team going forward in the forthcoming years, recognizing the fact that the trials we have at our disposal remain very limited in their selection of patients within the studies, which we are widely citing, widely discussing, and widely presenting at meetings around the world. We need to remember, as highlighted in the right-hand panel of this slide, that the low-risk trials did not include low-flow aortic stenosis, they did not include bicuspid valves, they didn't include Georg's patients with multiple valve disease, they excluded severe coronary disease, and they selected patients who were suitable at low risk for either surgery or TAVI. And we all recognize that in reality, when we discuss tens of patients week in, week out as part of our heart team meetings, that many of these patients lie out with the current randomized control trial evidence. As Giuseppe has pointed out, we also need to think about important future considerations. We have concerns regarding the feasibility of coronary access in many of these patients over maybe 10 or 20 years of follow-up. And we've heard from John about some of the technical challenges associated with these particular patients. We also do not know it yet at this stage, and this slide comes from Vinny Bapat, what it will be the best second intervention in terms of a patient with a degenerating TAVI device, which was perhaps put in their 6th or 7th decade. Indeed, will TAV-in-TAV be the best option, or will there be a role for surgery, which may frequently be a complex second-time intervention? And furthermore, we face the practical challenge of delivering the workload. In the UK, if we were to deliver the randomized control trial portfolio, we would need to triple our TAVI activity in the next 3 years. And put simply, we do not have the resources to do that. And then when we move into the field of mitral valve disease, which we've heard is a much more challenging arena, we need to recognize that there are many hundreds of thousands of patients internationally who, according to the COAP trial, will benefit from edge-to-edge repair. But as we've learnt, and Jorg and I have spent many hours on email over the summer holidays, trying to work together towards a consensus approach to the selection of these patients and the management of these patients by heart failure physicians, interventional cardiologists, and surgeons in collaboration is a very challenging task. And for that reason, I think we need as a community to take stock of the situation, and we need to realize that this is not about interventional cardiologists fighting with surgeons. It's not about budgets within our institutions, but it's about what's right for patients based upon the available evidence and the limitations of the current technologies and our ability to apply them at vast scale. Thanks very much.
Thank you, Bernard. I'm sure you will have a lot of questions. And if not, I will have some. Giuseppe, please.
I have just a comment about the Art Team 2.0. I think that, as far as I know, considering different national societies, one of the most important points of the Art Team is that in the next future has to be placed upstream to the surgical refusal. That's the point, because currently what we have is that we have the surgical refusal, both mitral or aortic stenosis. At that point, the patient will go for discussion for the Art Team. So I think as European societies, we have to work on that, having all the evidence that for lower risk patients, the accurate patient selection for the TAVR, for the mitral also. I think we need to move upstream this kind of discussion. This is something real.
I could not agree with you more, Giuseppe. I mean, we started with heart teams effectively being a gatekeeper for TAVI, and that was to do with finance, it was to do with limited evidence. We're now in an era where often the heart team is really discussing the technical aspects of device selection and route of access. And I agree with you, we need to move the whole thing at an earlier stage of the patient assessment pathway, because then we will be genuinely working together to do the right thing.
John, what's your view from the other part of the Atlantic?
Well, for a long time we've been doing this with echo and a referral to another group, and then a catheterization, and then discussion, and then a CT and more discussion. This can take months. And I think what we're moving towards is people will have a clinical diagnosis, an echo, they'll have a CT, they'll have a decision, then they'll have a procedure. And the decision really needs to be at the beginning, because the default will be TAVI for most patients. And that's where the heart team comes in, is deciding who is not a good candidate for TAVI. And I think there'll be many of these people with LVOT calcium, outside the size range, coronary access issues. Repeatability will not be possible with a TAVI implant in some patients, and they need to be identified at the time of the first TAVI, not the second. Determine both the TAVI site, and some patients may preferentially have surgery.
So, Bernard, we have some questions from the audience for you.
So I think the important answer to the first question is that the Heart Team 2.0 isn't about just doing TAVIs. It's about making the right decisions for individual patients. So I think we have a very strong argument from Stefan that the concept of surgical risk is no longer the determinant. I think we should also try and get rid of the concept that it's all just about age. And if you're above 80, you get a TAVI, and if you're below 75, you get surgery. We need to be more intelligent than that. We need to choose the right device for the right patient at the right stage of their valvular heart disease. Most of the diseases we're talking about are degenerative, but we need to recognize as well that as we evolve as a global community, then rheumatic valvular heart disease is also going to come on the radar. And we need to work out a 30 or a 40-year journey for many of these patients, and also factor in things like childbirth and the ability to carry pregnancy. So I think we need to think intelligently as a community about how we all work together to do the right thing for individual patients. So I don't think it's just as simple about durability. Do you think the heart team should include surgeons? Of course it should. Surgeons are a very important element of the heart team.
Not involved in the transcatheter procedures, without conflict of interest, I think, what's behind it.
Yeah, absolutely.
But in that case, we need interventionalists who do not structure.
Okay, so I agree. We need to have true surgeons in the room to represent the true role of surgery. And then there's a question about logistics, about all the members of the heart team meeting the patient to make decisions. Well, as John says, we need to make it light touch. We can't make this cumbersome so that it delays assessment and decision making. The model we have at St. Thomas is that we have simultaneous clinics with interventional cardiologists, imagers, and surgeons all in the same clinic area, so that patients can move freely and get the value of 3 opinions in one visit to the hospital. So that is the way to deliver it. You can't have serial assessments by different specialists, because that just delays and paralyzes the process.
I mean, the heart team will not survive to this 10 or people gathering to decide on one patient on one case. This is impossible. It has to be light degree.
What I would make as an important point, however, is that we need to have somebody in the room who is the patient's advocate, because so often decisions are made about patients with no one in the room having any knowledge of their clinical situation. And I think that's a practice that we need to try to close down.
But this is also means that we are in a position of being accused or not doing the appropriate thing for the patient, which we cannot accept here. I think at the end, and this is my own practice, we have to reach a point where we have been standardizing the way of working. We trust each other, and we know what's good for the patient and what's bad for the patient. And I think we don't need to meet every time with 10 people to decide if this aortic stenosis is better being operated or not, or having a TAVI or not. And this we may need time, but we don't need goalkeepers for this. I mean, our ethic, the results and science today are the best goalkeepers. Giuseppe?
I don't want to be too simplistic, but there is a way, it is a simple way to standardize and objectivate. We have the S guidelines related to, we have a list of variables that says, this list of variables favor TAVR approach. We have other variables that favor surgical approach. I think it's a good practice to start every heart team with this report that says that we have 7 points in favoring TAVR against surgery or vice versa. That point, this is one way to objectivate, because this is up to also the clinician, is not up to the interventional cardiologist or the surgeon. But this is, the way to start with a very fair discussion without any muscular position from the surgeon, for instance.
I mean, I can speak for my community because, we have no single procedure that have been investigated the way TAVI has been investigated. Thousands of patients have been treated worldwide with the results we know, with even the valves showing superiority. So I think we have to admit it. Now, it's time to sit together, because we've seen a lot of iterations coming from the industry, but in the real world, we still have some complications that we can address. And the only way to address them is by working together. Stefan?
Yes, I think I make only 2 comments. Obviously, I think the patient should be at the center of any decision making, and therefore, fortunately, they are better and better informed, and they will form an integral part of the decision making. The second point is I think probably we will move to specialized valve disease centers where the expertise in terms of diagnosis, imaging, non-invasive treatment, all interventional techniques and all surgical techniques will be available at the highest level. And I think that's probably a model where we need to move to, that at the end of the day, you can offer the best therapy for any individual therapy. And therefore, I think the distinction between, let's say, interventional and surgical techniques, hopefully in the future, is rather artificial, and we engage more into a common education and training of cardiovascular disease specialists, where they all start with cardiovascular medicine, and at the end some will go more in the diagnostic specialty, some will go in the interventional specialty, and others will practice the surgical skills.
There's some radical changes ahead, and let's embrace them.
Yeah, and surgery and surgeons must embrace this evolution, and I mean even our technical approach for the patients themselves. And I think we do some difficult, dangerous cases. And for example, a lady of 70 or even 65 years old, in whom we were sure that we'll be implanting a 19 valve, and for whom, if you want to do a valve-in-valve, you have to do a basilica. I think it's better going straight forward for a TAVR, which takes you away of all of this, and then choose the right appropriate valve based on what will happen in the future. I think we have enough tools today, we have enough knowledge, we have a lot of experience that we can use and face really things, sit together and write the standards of a new era based on this heart team approach.
Okay, wonderful. I can see that there are 3 minutes left at our disposal, and I can see that it's also well past 7 o'clock in the evening. So I think we should draw the session to a close. I think we've had some very meaningful and stimulating discussion. We've had some excellent presentations from a star-studded international panel here. We've had some good philosophy about the future, and we will continue those conversations throughout the rest of this meeting. So thank you, Thomas, for co-chairing with me,
Bernard.
and thank you all for staying on here in the main arena. Thank you.